Welcome to part 6 of our lectures on psychological disorders. In this particular section, we're going to take a look at a variety of other disorders, not as in detail as we've looked at the ones prior to here, and you can see kind of the list that below that unfold for this. The first one, looking at our art up here, the representation of Jekyll and Hyde, really characterizes the first type of disorder that we're going to take a look at, which is referred to as dissociative disorder. In this, commonly what we see is that our conscious awareness becomes separated or dissociated from previous memories, thoughts, and feelings. And this dissociation is actually kind of a defense mechanism. And what it is, we see, is basically a breakdown of our memory, our awareness, and our identity or perception. And take a look at some additional symptoms here. Generally, people have a sense of being unreal. It's kind of like I'm living an unreal existence, but I'm aware of it. It's not that, I'm not aware of this. I actually have awareness, and it produces tension. Being separated from the body, and that is in a sense of kind of almost being outside my body, separate from it. And then the last one, which is kind of related to the second, is kind of like watching yourself as if you're in a movie and you're sitting out in a theater seat and watching yourself go through life. And it's kind of like you know this isn't real, but it's so kind of mystifying to you or surrealistic in the way that it plays out. Maybe the better way to take a look at this is to look at actually 5 different types of dissociative disorder to give you a little bit better feeling. The first one is depersonalization, and this is where people go through periods of detachment from self or surroundings, which may be experienced as unreal, in the sense that lacking in control of or outside of oneself, while retaining awareness is only a feeling and is not reality. It's kind of like I feel depersonalized. I've got these feelings. I know it's not realistic, but I still have these particular feelings. So I haven't lost complete touch with reality, but I just can't get myself together, and maybe I'm feeling less than human or something like that in one of these things. And in schizophrenia, we saw depersonalization be a characteristic of where a person might think that they're in fact an orange, or they may think that they are a robot, and kind of being one of these delusions that an individual will go through. And here in dissociative, we may have this delusion, but we're not totally lost in it. We know that this is not real, but we still can't shake the feeling. The dissociative disorder, just a simple dissociative disorder, which was formerly referred to as psychogenic amnesia, is a noticeable impairment in recall resulting from emotional trauma. It is a form of amnesia, but amnesia, oftentimes when we talk about it, is generally the result of some organic type of situation. It could be brain injury. In the case of HM that we talked about, earlier on, the gentleman with the epileptic surgery that went, badly for him and destroyed his hippocampus. That's an organic related type of amnesia. Here in dissociative disorder, it's kind of like I separate myself from being able to recall things because of the emotional trauma that occurs. Now, a lot of us maybe will go through a real, traumatic event, and we can't recall it immediately, and that's common. The brain's kind of blocking it out, giving yourself a chance to catch up and things like that. And but eventually, though, generally over a few weeks, we'll be able to recall the events. Here, we can't recall it for an extended period of time, and that's when we become concerned. It's a persistent type of amnesia, but it's not related to anything organic. Dissociative fugue is the one that's really peculiar. And here you can see physical desertion of some familiar surroundings or experience of impaired recall of the past. The second sentence here is even more interesting. This may lead to confusion about actual identity and the assumption of a new identity. One of the stories that I remember when going back when I was studying this in graduate school was a gentleman who was a car salesman out here on the East Coast. And he was, the recession hit. He was going through, just a terrible period in his job, basically losing his job. He had a wife and kids, the house was being foreclosed on and everything else, and he just couldn't cope with the stress. And what happened is he literally picked up and left, moved out to California. Now, his wife, he didn't tell his wife, anybody, where he was going. He gets out to California. He assumes a new name. He has no recall of ever being married or having children out here. His wife actually hires a private eye. They track him down across country and find him. And this guy's like, basically in denial that I don't know what this woman's talking about. I never lived, let's say, in New Jersey. I wasn't, John Smith. I'm, Joe Jones now. And, I've got my own, life here. I don't know what you're talking about. And it's just an extreme way of the brain coping with a very stressful situation that it was incapable of coping with. And that, but you don't find a lot of them, but you will find them on occasion where a person will go through what we call dissociative fugue. Okay? Dissociative identity disorder is formerly what we used to call multiple personality disorders, and this is the one that the movies love to have, is where basically there's an alteration of two or more distinct personalities with impaired recall amongst the personality states of important information. In other words, we literally develop two distinct personalities inside ourselves, and neither one of them is really aware of the other personality. And you can imagine how this is confusing there. There was a very famous case down in Macon, Georgia, who was studied by a Dr. Thigpen, and a movie was made about it later on, The Three Faces of Eve, and it involved a young girl who, at a very early age, her grandfather died back in the old days when they used to have the funeral in the house and, bring the body in, and everybody would go up and, kiss the person goodbye. And Eve just couldn't bring herself to kiss this beloved grandfather goodbye, produced a lot of stress. And from there, she developed two personalities. She had Eve White, the very prissy, goody-goody two-shoes, and then she had Eve Black, the kind of disobedient, mischievous girl. And Eve started to get in trouble, and it's kind of like, well, I have no recall of doing any of this. I don't know why you're saying that I was here and that I acted that way. I would never act that way. And not being aware of the Eve Black personality. As she started to grow older, what she started to find is that Eve White, who wore the, kind of prissy sissy dresses and things like that, now is finding clothing hanging in her closet that was very, let's say, seductive and revealing. And it's like, I don't know where these clothes come from. Where do they show up from? Who keeps putting these clothes here? But it was when she was in that Eve Black mode, she was out trying to entice the boys, which Eve White would never do. And eventually, there is a collision somewhere along the lines where the various personality states are going to start bumping into each other. And there's going to start to become an awareness of one or the other. And, that's where, a lot of confusion obviously comes in their lives. But we've actually documented cases of 17 and 26 different personality disorders within an individual. And we'll talk a little bit more about this one. This is the one that's the most controversial of all 5 dissociative disorders. The fifth one is just our catch-all category. It's kind of like the undifferentiated schizophrenia that we talked about before, is that when we can't put a person into a particular, pathological dissociation, we dump them into this group. They're having dissociations, but not characteristic of any of those before. The prevalence of this disorder is as high as 10% in the general population to 46% in psychiatric patients. Now, this is patients that generally wind up in mental health institutions. The percentages have increased significantly in the past 4 decades. And the prevalence of this used to run maybe 1 to 2 in 1,000, and now we're up to many as 10 in 100, and kind of like what's going on. The other perplexing thing about this is that there's very little evidence of dissociative disorders outside the United States. You don't find it overseas. You don't find it in Asia. You don't find it in Africa. You don't find it in South America. And in fact, in the book, the British reference is that wacky American disorder, and it's kind of like, because it just really doesn't exist anywhere else. Well, why doesn't it? What's going on in our culture then that may be triggering this? Okay, so the critics then are very suspicious of the increase in the diagnosis of dissociative identity disorder in the late 20th century, and also because it's not found in other countries. What some of the critics believe is that essentially that it may just be role-playing. That maybe American psychologists and psychiatrists are very suggestive in therapy, and we make these suggestions, and people are more than willing to cooperate. They did one thing under hypnosis, which was used to bring out these multiple personalities in many cases, and they hypnotized people who did not have dissociative disorder, and then under hypnosis, using more or less leading questions and implanting thoughts, asked for them to be a different personality, to bring out a second personality. And almost in the study, almost all the patients that they did this had a new personality emerge, suggesting that maybe we as Americans are very susceptible to suggestibility, and that we merely role play out these suggestions, and that dissociative disorders, rather than being really truly psychological imbalance, psychopathology, is more role playing. Another explanation is that it may be a learned response that reinforces reductions in anxiety. I think in the case of the Three Faces of Eve, the Eve Black personality emerged to help Eve White cope with the extreme stress and trauma that she had from this incident of having her grandfather's body in the parlor of their house, and being required to go up and kiss the corpse, which she didn't want to do. And because she couldn't adjust with it, she couldn't cope with it, probably a lot of frustration that she didn't stand up for herself and tell somebody she didn't want to do it. Well, all of a sudden emerges this Eve Black who will tell anybody anything. And as if somebody's getting in her face, she's going to tell them to get out of her face. And so we see this kind of second personality emerge. However, in a kind of unique, very, very unique way, one personality is not aware of the other personality in the individual, and generally only we start to become aware of it as we start to trip up in these different roles, and people start asking us about, gosh, the other day you were like this, and today you're like that. I don't understand. What's the matter with you? Okay. From there, then, we move to another set of disorders that we refer to as somatoform disorders. In somatoform, we have soma, which means body. So we're going to talk about disorders of the body. When we look at somatoform disorder, then, it's the name of a group of conditions in which physical pain and symptoms a person feels are related to psychological factors more so than any physiological factor. Okay, and generally the symptoms that they have can't be traced to any specific physical cause. You got a lot of tension, you got a lot of aches and pains, but there's nothing the matter with your muscles, your bones, or anything else. And it may be that this is a somatoform disorder. It's basically a discomfort or pain that is brought about psychologically rather than physically. In people who have somatoform disorder, as you can see, medical test results are either normal or don't explain the person's symptoms. And this is kind of what got Sigmund Freud rolling along. Back at that time, we referred to him as hysteria, or what we'll refer to as, conversion disorders. But it is that basically people had these, from nervousness, or when he was studying nervosa, is this nervousness that came about, and we wound up with these various symptoms. As you heard me say earlier in the course, that some medical doctors indicate that as maybe as much as 75% of the cases that show in their office are related to stress, tension, and nervousness. So, okay, let's take a look then. We have the first one is called somatization, and it was formerly called hysteria, and that dates back to Sigmund Freud. He actually used to think that the womb kind of breaks free in an individual and gets lodged in different positions, which causes basically these, false physical symptoms. One of the things is if the womb's getting dislodged, all of a sudden we know, hey, this is a female thing and not a male thing, and that's part of that bias that people accuse Sigmund Freud of having. But here, in a somatization disorder, it's characterized by recurring, multiple, clinically significant complaints about pain, gastrointestinal, sexual, and pseudo-neurological symptoms. And they have aches and pains throughout their body. They have gastrointestinal problems, pain in their stomach and things like that, stomach cramps, sexual dysfunction where maybe having sex causes pain, or that during their menstrual period they experience far more significant pain and discomfort than would normally accompany it. And then the pseudo-neurological could be headaches, migraines, where there's no evidence or physical cause for that. In order to diagnose somebody with this, we have to have a history of complaints, and we usually look for 4 or more different sites of pain. And actually, in the true diagnosis, we're looking for 2 of those to either be related to sexual or to pseudo-neurological symptoms or gastro. So it's not just aches and pains around the body, but we have to have 2 out of those 4 have to come from either the gastro, the sexual, or the pseudo-neurological. So it's in different areas, not just hypertension where you got, neck pain, shoulder pain, chest pain, things like that, but coming from different parts. The symptoms cannot be fully explained by any general medical condition that is going on, and that the complaints are not feigned or faked, as in what we refer to malingering or factitious disorder. Okay, so you genuinely think that you feel these things, and you're not feigning them. You're not faking them. You really feel like you feel them. However, we can't find any physical basis for them. Okay. Somatization. The next one is hypochondriasis. Excuse me here, which is changing to what we're going to call health phobia, or health phobia now, which we're going to call illness anxiety disorder in the future. I kind of liked hypochondriasis and hypochondriac and that, but we're trying to move away from some of the psychobabble and use names that people will understand better when we're describing psychological disorders. So illness anxiety disorder really addresses what we're talking about. Hypochondriasis, or calling a person a hypochondriac, that's like, what's that? That's one of these big $5 words. So, but anyways, in this particular disorder, it occurs when a person believes that normal body functions, such as grumbling of my stomach, or minor symptoms such as a common headache, are symptoms of much more serious disorder. So the grumbling of the stomach is, oh my God, I got cancer. The headache is, oh my God, I've got a tumor in my brain. And they build a mountain out of a molehill. And then anything that they do, these are people who are constantly running to their doctor, complaining about, they're taking these mild symptoms and fearing, that they're the worst possible imaginable disorder. The hypochondriac is the type of person, you open up their medicine cabinet and they got tons of pills and medicine for all sorts of things, because, the minute they get a runny nose, oh my God, I'm going to come down with pneumonia. And so they're pumping themselves full of medicine and things like that. And they can be difficult to live with, very difficult to live with for, a mate in this situation, because they're always sick than that. Okay. The next one is conversion reaction, and this is one that's kind of interesting. It's when physical symptoms that are similar to a neurological disorder develop when no present neurological disorder is there. Now, such as the paralysis of an arm or a leg, loss of vision, hearing loss, or seizures are common symptoms. Okay, and when people are under stress, these symptoms may get worse. One of the more unique ones that I had an opportunity to see a number of years ago was at the Cleveland Clinic up in Cleveland, Ohio, and it involved a young woman who came in all of a sudden blind. She woke up, went to bed one night, being able to see perfectly fine, woke up the next morning, not being able to see at all. She somehow became blinded in the night. That would be an extremely rare occurrence, except for maybe a brain tumor. Well, they run her in, they do a scan, can't find anything in the brain. And with us, they call in the psychiatrist. And the psychiatrist, sits down and, talks with her about this. And one of the things that he did, this was an internship that I was doing at the time, is, he says, come with me. He said, we're going to do something interesting. He says, I got a hunch about this. I think she's suffering from a conversion reaction. That somehow some stressor out in her life right now is building up extremely strong. And by not seeing, it alleviates the stress. Okay. And what he had picked up on in the interview is that she was in the middle of final exams and she was feeling very stressed, very nervous about final exams. And the way that he demonstrated this, he would put things in front of her. She couldn't see him, anything else. So he took her down to a room that she had never been in before. And before she entered the room, he rearranged the furniture such that if she walked straight across the room to him, she would have to fall over or stumble over this furniture. So he has me wait outside with her. He goes into the room, gets to the other side, and then, asks me to bring her in. And we bring her into the room, and I hold her there, and she's kind of nervous because she can't see. And he says, Mary? And she says, yes. And he says, can you hear the sound of my voice? Yes. Can you tell which direction my voice is coming from? And she says, yes. And he said, I would like you now to walk to the sound of my voice. Now realize, if she walks straight across the room, she's going to bump into furniture. What was incredible is literally to see Mary move and weave her way around the furniture, claiming that she can't see, but having this kind of sixth sense, so to speak, of the furniture. Actually, her neurological circuits were working fine. Her eyes were working fine. All the receptor cells and everything are firing. The rods and cones are sending messages back through the optic chiasm to the visual cortex. But in her mind, she blocked it out because basically she couldn't see. No professor could require her to come in and take her exams. And he demonstrated this very well. Some other forms of conversion reactions we see at time or are nervous tics that individuals will have. Sometimes stuttering may be a conversion reaction. And, where they help us sometimes in the wrong sense, alleviate putting us into stressful situations. I really hate public speaking, and if I stutter, nobody's going to ask me to get up and publicly speak. Okay? So, anyways, from there, then we move into sexual and gender identity disorders. And just to run down through here, I don't want to belabor this, but we have hypersexual disorder, which basically means that somebody is always interested in sex and has to engage in it. We have a sexual aversion disorder, which is the opposite, is that people avoid sex. They fear sex, and they avoid any situation in which there may be sexuality. Gender identity disorder is basically where we have gender is going to shift over to what we call gender incongruence. But in a gender identity disorder, it may be a male who is born with an XY chromosome structure, feels that Mother Nature has pulled a cruel trick on them and giving them this male body because they actually feel that they are a woman. And we will refer to this as transgenderism or transsexualism. And it's much more prevalent in males than it is in females. But it is a disorder that we see. Exhibitionism is the old street corner flasher, who's opening up his raincoat and has no trousers on down below. Many, many years ago, we had one of those on campus who was going around at our evening classes and, would open up a door into a classroom like as a walk-in, we'll open up the coat, flash, and then take off. And that. No, we never caught the guy. So, anyways, pedophilia is the one that really is upsetting to a lot of people. Is a person who likes to prey on young children. Prepubescent is the way that we would identify pedophilia. Sexual masochism disorder is a masochist is a person who enjoys having pain inflicted upon themselves. And so in this situation, in order to gain sexual arousal, a person is going to want to have sexual pain inflicted. And, this is what leads to some of these alternative clubs that you hear about where, they've got people, tying people to racks and things like that and whipping them or putting them in through, into extremely humiliating initiating circumstances, and this produces a high level of arousal in an individual. And a lot of times you'll find in these sexual masochism disorders that eventually it progresses to the point where they can't get aroused unless they're involved in some type of masochistic behavior. And every sexual masochist needs a sexual sadist. And the sadist is the person who enjoys inflicting pain. There are some people who can't get aroused without, inflicting pain upon others. And, that's a heck of a date to bring home, isn't it? As the person who's like that. And it's going to be, maybe a very high risk evening with that person. But there's some people that want to bite, they want to chew, to go into a lot more violent or aggressive type of behavior. Transvestic disorder is your local garden variety crossdresser, a person who enjoys wearing the clothing of the opposite sex. Generally, the key feature of transvestic disorder is not just the liking of dressing up in clothing of the opposite sex, but they do it to produce sexual arousal, and generally culminates maybe or most often in masturbation. Or spontaneous ejaculation when they're dressed like this, and eventually it gets to the point that the only time they can orgasm is when they're cross-dressed, and so we would classify that as transvestic. Just wanting for a male to dress femininely or for a female to dress masculinely, we wouldn't refer to as transvestic disorder. You may presume that they're a cross-dresser, but it wouldn't be a transvestic disorder because it doesn't involve the sexual side of it. Voyeurism is your local peeping Tom who likes observing other people, the type of person who's always drilling holes in bathroom walls or crawling up in the ceiling tiles to peer down to see people nude, looking through a young girl's window as she's changing at night, something like that. And erectile disorder, if you watch any of the late night TV and you see the Cialis or, I'm thinking... blocking of the most popular drug there, but basically it's people who suffer from ED, basically for males in this situation who are incapable of achieving erection. So, okay. From there, then we had the last set of major disorders that we're going to talk about, and these are the eating disorders. And what we have is anorexia nervosa. And basically in anorexia nervosa, we have people who just stop eating for the most part. And that's what really kind of sets it out. Usually begins with a diet, and a person, we usually see it in teens, and 9 out of 10 who suffer this disorder are generally female. That 1 out of 10 males generally, often, for the most part, are gay men who also generally are very conscious about their weight. As much as women are. We'll usually see a drop in weight that is significant, 15% or more below their normal body weight. They generally following that weight loss, they still feel fat. And we have the image here of a young lady looking in the mirror put out by the Bulimia Anorexia Society. And what you can see is that we see a very slender girl looking into the mirror who's seen a girl who weighs a lot more, and probably we're looking at maybe 15, 20 pounds difference in what the image that she sees back. And then it's always that they kind of see a heavier, chunkier person, and therefore they feel that they've got to lose more weight. They may perceive, maybe I'm putting on weight, so I need to diet even more, or I just need to stop eating. And so, but they remain obsessed with the fact of gaining weight. 50% of these will display what we call a binge purge depressive cycle, is that they may get hungry and they'll binge and eat all sorts of junk food, then they'll purge it, and then they'll go into a depressive cycle. And one of the things they really kind of starts to tell us is whether it's just a fad diet or a diet just gone wrong, is that depressive cycle that we'll see in there. Some people will binge and purge. I really want a pizza, but it's not on the diet, but I'll eat it and then I'll throw it up before my body can get any of the calories out of it. And some people will do that, but the depression is one of the things that usually sets us off, is they get very depressed about their weight. As hard as they try to lose weight, and they generally do lose weight, they still do not see their body image changing, which is the psychological factor. In bulimia, it's often triggered also by weight loss, but the weight loss is broken by gorging on forbidden foods. It's kind of like, oh my God, I really want some ice cream, and then they go in the refrigerator and they wolf down a quart of Ben and Jerry's, Jerry Garcia ice cream, and it's like, wow, this is great. But then they start to feel the guilt, they feel the fear of being overweight, and they run off to the bathroom and they throw it up, and then they go for a while, and then they'll binge on something else, and then they'll go throw it up. The one thing about the bulimic is that they generally are going to eat, and when they eat, they purge on things that generally is junk food, ice cream, Twinkies, candy, cake, things like that. And it's not just eating a little bit or, what it is eating a lot of it. And then, with knowing that, hey, if I go throw it up right after, whereas if I purge this, I'll get minimum calorie consumption and it won't affect my weight. And they literally go through this, but the problem is that they start binge purge all the time, developing, a definite preference for eating the sweets and the low protein foods, and they're always purging. So then we see significant weight loss. Both anorexia and bulimia can lead to death. As we say, we're primarily concerned about it in women, particularly a lot of times in athletes at high school and college level. We're finding, the gymnasts, who are wearing the spandex, the volleyball players that are wearing the spandex, and they start to look for that ideal image. How do I look? I can't have any bulges or anything else. A lot of times, those athletes that are particularly wearing kind of body revealing outfits are oftentimes our greatest target. Even the stunts and tumble teams and things like that will get into this anorexia and bulimic behavior. As you can see up here, 50 to 75% of the individuals with eating disorders will experience depression. And that's one of the things that really tips us off as professionals, is generally when we see depression along with a perceived eating disorder, that's when we start to focus in on bulimia or anorexia. 1 in 4 that are diagnosed with an eating disorder oftentimes will exhibit obsessive compulsive disorders, such as that binge purge. They start thinking that they're fat and they stop eating, or when they eat, they throw it up. It's oftentimes comorbid with alcohol abuse. It's not uncommon to find alcohol abuse or other drug abuse with these individuals. The causes? One is we find it's actually highly inheritable. And interesting enough, in some research studies, 56 to 84%, and that is really high. So if you got a sister who's anorexic or bulimic, very likely you would be. If mom, or possibly dad, but pretty rare for dads to be this way, there is a tendency for it to be passed on. And we're looking at genetic characteristics, so basically DNA and how that DNA cell is conveyed or portrayed within an individual. Brain chemistry, we find serotonin and norepinephrine levels different in individuals here, and we're looking at that. And then environmentally, the idealization of thinness, and both within the individual's mind as well in society around them. We had the young lady here who's, looks like she's walking down a fashion catwalk, and look at her. I mean, look at that thinness, and this is the way that we portray that women should look like, and that thick is not in on the fashion circuit, but be very slender. Be that size 2, that size 3, size 4, whatever. And it's kind of like size 12 or size 14, which probably more women are up in that range. That's too big, and you should be lower, and you become obsessed with that. Okay. From there, we're taking a look at personality disorders and just coming back into the antisocial personality and talking a little bit more about it. And we can see here is that personality disorders are characterized by inflexible, enduring behavior patterns that impair social functioning, and they're usually without anxiety, depression, or delusion. Okay, without those. Okay, and so we look at the antisocial personality. And you can see, like mood disorders, here we find that they have biological and psychological reasons. We find it similar. One of the interesting things is, like antisocial behavior, it generally starts in very early in life. Can start is essentially as early as around age 8. We can start to see these patterns beginning, and what we see is that their brains don't function like other kids' brains do. And we come over here and we look at adrenal secretions, which go along with stress. When we're under stress, when we do something wrong, we feel stressed, and our adrenal levels are going to kick up. And what's interesting is that when we look at individuals who have no criminal conviction as children, and we look at those who have criminal convictions, non-stressful event, they're low. But look at when we go to a stressful, those in criminal convictions, we see that their adrenaline system doesn't kick up. It doesn't produce the same level of stress, or maybe what I should use in this case, distress, which generally we're going to feel bad. Our conscious is going to kick in here. The superego is going to do its thing, and we're going to back off because we feel bad. But we don't, what we see is that antisocial personalities don't get those same chemical signals to the brain. An additional study that was done by Rain back in 1999 and in 2000, what he did is he looked at the brains of 41 people who were convicted of murder, and in doing PET scans on them, you can see what he found down here is you look at the normal brain to the left there, and you can see all this level of activity. The yellow and the red zones being high activity. You look over to a murderer's brain, and there just isn't as much stimulation. Okay, so, when they do things that are bad, it may not produce a stimulation. In fact, some look at it and say, well, maybe because their brains don't get stimulated, they go to performing these really drastic behaviors to get stimulation. In order for them to really get aroused, to really get fired up, they have to go to abnormal levels of activity to get that stimulation, that we thrive for that. So, two different ways of looking at this in that perspective. Okay, so the antisocial personality then is a disorder in which a person, usually men, exhibit a lack of conscience for wrongdoing, even towards friends or family. I had a antisocial personality in the family a number of years ago, and the kid would just rip off mom and dad. And they'd go out of town, they would come home from not find the stereo there, the silverware gone, the TV, things like that, and just took it. And there was no evidence of remorse. And basically, they just did it because they needed some money to buy something that they liked, and in this case, it happened to be drugs. But the thing is, there's no feelings of remorse or guilt at all in the person. And as you can see in the past, we've referred to this as either sociopathic behavior or psychopathic behavior. Okay? Taking a look then, to wrap it up here at the end for our lectures on psychological disorders then, what are the rates of psychological disorders? And when you can kind of look down the list, and you can take a look, but phobias is definitely the most popular one out there at 7.8% that we find. Mood disorders, depression, we refer to that kind of as the common cold of disorders at 5.1%. And you can look down, the other ones. Fortunately, antisocial personalities, which generally wind up in jail, are only at 1.5%. Here's a study that was done by the National Institute of Mental Health, and what they estimate actually is that 26% of adult Americans suffer from a diagnosable illness in any given year. And as we go down that, you can see which ones are most prevalent. Phobias is up there at 8.7. Mood disorders in this particular study edges out phobias at 9.5, and that's where this notion of it being kind of the common cold, the more popular type of disorder, is from this study that was done by the National Institute of Mental Health. So you look down those there. Obsessive compulsive about 1%, schizophrenia 1.1, and post-traumatic stress about 3.5, and pretty much up during war years and things like that. This study has been since 2008, and the Iraq and Afghanistan conflicts certainly probably play into the prevalence of this disorder, although it can happen for many other reasons other than just war trauma. But generally, when there's real significant heavy fighting, things like that, and our soldiers are engaged in it, we're going to see the higher PTSD. This is another interesting one. Here we're back to the World Health Organization 2004, and they're looking at the prevalence of psychological disorders around the world. And look at the United States. When we're out there, we lead in any mental disorder. We're out front, significantly in front of other countries. And then when we look at serious mental disorders, fortunately we drop way back from that, any disorder, but still we're pretty much the leader around the world. Some will say, well, we have better healthcare systems and we have better reporting and recording of the illnesses, and that, in fact, may be a factor in this. But, it certainly has us, taking a look at what's going on in our environment, everything else. United States, very fast-paced. It's more what have you done for me lately than what have you done for me all along. And that can produce a lot of stress and a lot of uneasiness in life. Some factors that are related to risk or protective factors for disorders. And one of the things is that as you look at the top of the protective factors, we see exercise sitting up there. And one of the things is a healthy body equals a healthy mind. And there is a lot to be said for that. And a lot of psychotherapists, a lot of times when they find people being relatively lethargic, sitting around, not getting out and doing things, will oftentimes recommend some type of exercise routine. Whether it's just working out in the house, maybe getting out to a health club, and getting physically active many times can help a person improve, and it also can help fend off psychological disorders, particularly like anorexia and bulimia, right off the top of the bat. Can alleviate depression because we feel good about ourselves. We're out doing something to improve ourselves. Can, help stem then, those depressive cycles. So, you can look at here, what are the risk factors and where are the protective factors, and maybe use that as a checklist to go down and say, okay, where am I at? And am I at greater risk, or do I have a lot of protective factors that will fend it off? And the last thing is just to take a look at a timeline of onset. As we've gone through and talked about a variety of disorders, we've talked about whether they occur in childhood, adolescence, or early adulthood. One of the things is that most of these disorders, about 75% of the disorders that we diagnose these days, start generally before the age of around 30. Okay, so if we start off and we look at our early years, around age 8 is where we start to see antisocial personality. The kids are very disruptive, very hard to control them, and we'll see this disorder emerge. Around age 10, we start to see phobias start to come into the picture. And a lot of times, if we're going to develop a phobia, we're going to see evidence of it as early as age 10. Around age 20, we're going to have alcohol dependence starting to show up, obsessive compulsive disorder, bipolar disorder, and schizophrenia, and generally are going to have presented themselves. In the case of schizophrenia, pretty much once you're out about 25, if it hasn't occurred, it probably isn't. Once you're over 35, slim to none chance that you're going to develop schizophrenia, and even the same with bipolar and OCD. So we see a lot of those occur very early on. Major depression generally is something that's going to show up probably by about the median age for most people who suffer from major depression is around 25. And all of these are kind of the median age where 50% are above, 50% are below, and that. But major depression generally is going to show up later. So, if you're beyond 25 and listening to this lecture, you're on that downhill track now in the sense of, then your odds are getting less and less each and every year than you will ever be a victim of major depression. And that's so. And these are the characteristics or trends that we see. And that wraps up our lectures, our series of lectures for psychological disorders.